He is professor of gastroenterologic surgery at Yale University, and he's the director of the GI Pathobiology Research Group at the same institution. He has written extensively, and he has so many degrees besides his MD degree, and also membership in esteemed societies, that there aren't enough letters in the alphabet to cover all of his qualifications. But more than this, he is a scholar and a man of letters. His lectures are renowned for their clarity, their insightfulness, and also their elegance, and for the very, very enjoyable and elaborate character of the illustrations. So we're in for not just an informative, but a very entertaining lecture. Dr. Modlin.
Well, I think first to thank Richard Warner for that very glowing introduction. You know, the first two initials of his name are RP, which is a real professional, somebody who's stood the test of time and done it with honor and grace. You probably don't know my mother wrote that introduction for Richard to give. I think she's the only person who would believe it. Anyhow, it's a great privilege to be here, and I just want to make sure, most times when you stand at a podium, you ask people, can you hear me okay? Yeah. When I give the talk, I usually have to ask, can you see me okay behind the podium? Anyhow, if I can begin, let me walk you through what's going to be a slightly strange way of looking at this. I told some of my colleagues in the audience earlier today, everybody you've heard so far has been a real clinical scholar, and a lot of them have been serious scientists as well. I don't have any of those aptitudes. I'm just a performance artist, so just bear with me as I walk through this. And I'm going to try to take some of the information that you've heard and just point at it a little bit and make you smile and think perhaps, and possibly even let you see that some of it is dogma, but it's the best we have today. So what I want you to do is just put on your bouncing heads for a little bit of time. Oh, it's a tough group, I can see that. Yeah. So, I'm going to firstly acknowledge what's really a wonderful meeting. It's quite extraordinary to come to these meetings, much nicer sometimes than the big academic meetings, and to talk to you about Net World, which is the world that we all live in. I thought I'd just put you in the perspective of where we are today. This is the original map of the area, and you see, of course, Vancouver as it stands today. And the city where it's located. I wanted to thank Maureen Coleman. I've always thought it was a strange, without whom this can never be put together, things like this. And I know exactly how much trouble and effort it takes to put this together. And of course, it goes without saying, the GE-NETS group, I looked at it, there are at least people from 6 different national backgrounds there. I was most impressed with the heterogeneity of the thought. And for those of you who didn't have the pleasure to be here last night, a wonderful dinner, an absolutely gorgeous talk, which one really appreciated, on how to take molecular medicine from Leonardo into the current day world. And the comments this morning were just as apropos. And also the pleasure of being with the audience of all the people who are here today. It's not often that you're in an audience which is so thoughtful, so intelligent, and also It's a special day. You've heard a lot of talk about isotopes and their role in nuclear nets. This is actually the birthday of Pierre Curie. Between he, his wife, and his daughter, I think there are 3 or 4 Nobel Prizes in that family. And also to make the point that isotopic medicine combined with molecular structuring is probably going to be the way forward. And I think you've heard that. I just show you some of the pictures. When Marie Curie came to the United States, she no longer had any money left, and the women of the United States collected $100,000 to buy her a gram of radium to work with. And then lastly, it's worth pointing out that there is, without doubt, a great deal of gratitude owed to the people who help underwrite these meetings, because without them, no individual institution or group of people can really put together things like this. I show you where the benefit comes. This is one of the early meetings run by the Solvay Corporation in Brussels in 1911. You see the red circles around some of the faculty present. There's Marie Curie looking at the table, Albert Einstein, and also in that room are Bohr, Heisenberg, and Rutherford. So within 10 years of that Solvay meeting to discuss the current concepts in physics and isotopes, there were 6 Nobel Prizes in that room. So these meetings are very important, and they convey information not only between the academicians, but between the patients and their physicians in this case. Now, let me say a few words about this young man who I'm sure everybody recognizes as George Vancouver. Yeah, you did. And he discovered this area while wandering around. Probably he was seeking Palm Beach, Florida, but anyhow, somehow he got up here. And his ship, interestingly enough, was called HMS Discovery. I think every boat in the British Navy was called Discovery, as far as I can figure out. And with him was a young man, his Lieutenant Puget, and after that was named Puget Sound. But it's interesting to note that it was called Noon Breakfast Point, where Vancouver is. So given the time of this lecture that I'm giving, it's very apropos. It's somewhere between noon and breakfast. Of course, when Vancouver passed away, he was much remembered for this. And I got one of the old pictures of him subsequently. And you can see from it that he probably had flush, and if he'd have been here, Wolin would have cured him with the vitamin S that he was offering this morning. I come from New Haven, Connecticut. This is the institution. This is a library where I did a lot of work. We can't afford the Ivy anymore. We sold it to Madoff, and it all went wrong. And I'm going to talk about expertise in NetWorld, whether it's an illusion, a delusion, or a distant reality. And I'm going to play with it a little bit, and I try to tell some of the people that I was talking this morning, don't take it too seriously. I just want you to think a little outside the box about what you've heard. So here is a recent scan that Eric Lude took of my brain last night. Don't ask me how big it has to be to operate on. Okay. What I'm going to show you is this is NetWorld taken from the Hubble telescope. Okay. It comprises patients, MDs, nursing people, hospital management, insurance companies, pharma, investigators, scientists, venture capital. And what you need to understand is that everyone in this room has a different perspective of NetWorld. So there is no one truth. So one has to think this through when one listens to some of the data that gets presented. Now, here's where NetWorld was defined, which is the NIH, the Summit Conference, which the details of which were published in 2008, and this is the current status of NetWorld and where the United States government, at least the NIH, thinks it should be going. Apropos of going to see the people in Ottawa, I went to see the political representatives in Washington about this, and I made it a very simple point. I said every person in the country is paying taxes, but some of them get diseases that the taxes are used to treat, And some of them have diseases that the tax money goes elsewhere, and that's discrimination. That got a summit conference set up within 3 weeks of me seeing the local congresswoman who was head of the Senate Appropriations Committee for the NIH. So I mentioned that too for strategy. Now, that world is getting bigger. Here is the SEER database and showing you over 30 years an exponential increase in neuroendocrine tumors. So the world we live in, net world, is getting much bigger. And if you look in net world, there are very specific areas that are getting much bigger, which is the tumors of the small bowel and the tumors of the rectum and colon, which are increasing at an exponential rate. So net world is not only getting bigger, but different continents in net world are changing, and we have to think about that. Now there's the question of expertise in net world. This is a person as put together from this picture of Plato and Aristotle. You recognize Aristotle always better dressed than Plato in these pictures. Yeah? A person wise through experience. Now, we're surrounded in this room by patients who are looking for people wise in experience. That's what everybody wants. The question is, how do you tell if somebody's wise through experience? Well, I'll give you a few opportunities to look at that. Here's the oncological expert, known only for his knowledge of the analog brothers, and we heard about those earlier. Right? The problem is, that's pretty good for most patients, but for practical purposes, that's what you need to be if you're an expert. These are the anti-cancer therapeutics available at the moment, and you need to be sure that to be an expert, you know all about this, and not about the one with the big injection or the one with a little injection. So I say that expertise requires a very broad database. Then if you go outside of the oncologist and you look at surgical expertise, this is completely different. Here is an expert surgeon. Okay? And the more fingers you got and the more things you can take out and the bigger the liver and the more things, the better the surgical expertise is, unquote, right? But in fact, the limits of surgical resection are usually defined by the plasma testosterone level of the surgeon. Come on, you loved it. You loved it. But yesterday there was a female surgeon who was very effective, and so I have to change that slide now. The problem with surgery is everybody's really, really interested in how much they can take out. But that's not the problem. The issue is, what do you leave behind? Are there any tests to know what you've left behind? Nope. Nope. But I took it out. You're okay. Don't worry about it. Yeah. Okay. So I'll get to that later. Now, if you look at acquisition of experience, this is what we like at level of training, level of institution, complexity of patients, number of patients, the diagnostic material, the complexity of therapy, and the years of experience, you know. The number of gray hairs on the head is counted as experience. Not true. I thought it was wonderful. Eric Liu said he was 15 years ago in high school. He didn't tell you they kept him in high school for 20 years, but... But what you're looking for is young, smart guys who understand today's technology, not people who can give you endless anecdote of they remember a patient who, you know, you don't need that anymore. That's history, you know. Okay. And then the question is expertise different in the levels of institution you go to? There's the one institution that just does the standard treatment protocols. That's good. Then there's the institution that does the novel treatment protocols. That means any company that comes to you, the bigger the air ticket, the greater the honorarium, and the more exciting the thing, you'll do that, right? So do you want to be in that institution? And then there are the teaching centers, which can be Spoken Hub, which can be state-of-the-art molecular genomic groups, and translational. And then everybody has to decide what level of expertise are they looking for and where are they comfortable with getting that. And this we haven't resolved entirely yet, and it's something that caveat emptor. I guess you all speak Afrikaans, right? Could you open the doors and eject that person at the back, please? I heard you were leaving early, but not early enough, you know. And the sole basis of knowledge is enshrined within the guidelines. And I'm, of course, hesitant to say they're negative because some of the great representatives of ENETS who put this together are in this room and are responsible for huge steps forward. They delineated what it had to be treated properly or the best available knowledge. But of course, it's worrisome that all knowledge on the subject can be enshrined in 119 pages by a group of people meeting in a series of exotic locations where they put together this knowledge. Of course, it's the best we have at the moment, but we shouldn't be satisfied with guidelines being the same as the Rosetta Stone, which is locked forever into a black basalt piece of rock, right? These guidelines have to be changed at very, very regular intervals. Now, then at the end, say, who is really an expert? Well, have a look here. Here's the graph of all the people who are self-acknowledged authorities. They're writing on the subject, and they're writing very extensively, as you can see. So, do you want your expert to be somebody who's written extensively on the subject? I'm not sure. If he hasn't written anything on the subject, I'd be worried. But nevertheless, expertise can be conveyed into print as well. Now, this slide was shown earlier. You remember I said illusion, delusion, and a distant reality. Here's the illusion. Some of you will see a woman walking through the forest. Yeah? Some of you will see a face. Some of you don't even know what I'm talking about. And, of course, you have to remember when people present information and data and such like, you know, different people see different things. And the PROMID study is a very good example. Some people see it as a panacea for the future, a shift in paradigm, a great step forward, one of the huge advances in neuroendocrine tumor disease. And other people say, look, it's a study with a very small number of patients, a very short change, a limited objective, and it doesn't fulfill the criteria. Which is right, which is wrong? It's an illusion depending on which you're prepared to go for. My own personal perspective is it's probably a great step forward. But the point is, with all the data you look at, it can be looked at in more than one way. So a lot of this information in net world and in the illusion area is like Alice in Wonderland. You all saw that movie. I saw it, and I wasn't even wearing the 3D glasses, and I enjoyed it. You know, so okay. So look here, the symptoms, they come and go. The PETs, the MRI, CGA, octreoscan, surgeries, analogs, cytotoxics, kinase inhibitors, angiogenesis inhibitors. Depending on which particular glasses you're wearing, depending on which particular bottle you drank out of, you know, the mushroom stuff, these things become more or less important. So illusion is a funny word when it comes to looking at some of the information. So you need to have an open mind when you look at it. The person presenting the information usually is fixated on the fact that information is correct. Otherwise, he wouldn't be presenting it. So there needs to be counterbalance when a lot of this information is presented. Now, I didn't mention radiopeptide therapy, and that's going to be talked about later, and that's also a tremendously controversial area, which may be of great significance as we move forward. We need to see. Now, here's an example of illusion. I show you this. Everybody knows this is one of the most amazing edifices in the world, right? So therefore, the illusion that's created is this is important and exciting, whatever you show with it. So when you number it and you look at the 5 somatostatin receptors, people start thinking somatostatin receptors are serious stuff, right? And then, of course, when you put something over it and you show the efficacy ratios, then, of course, there's the concept that somatostatin analogs are immediately linked to the Sydney Opera House and one of the great divas. But, of course, that's an illusion, right? There's nothing to it. Right? Nevertheless, we know the drugs are very important and very effective. What isn't an illusion is this data from the United States SEER database, which shows for the average person going to an average hospital in North America, there has been no increase in outcome of the treatment of their neuroendocrine disease in some 30 years. That's for the average patient in the average institution. That's not an illusion, that's a reality. Of course, if you look at the reality being different in different locations, you see Florida, Uppsala, Milan, UK, that's New York, Richard, that dot there. That's somewhere in Texas and somewhere out on the West Coast there. You see, when you go to those places, the reality is different. They will show you graphs which show that the outcome there is massively improved. So the concept being, if you get off a plane in Boston, your outcome goes up about 40%, even if you don't have a neuroendocrine tumor. I've given a lot of patients that if you want to go somewhere, probably Hawaii is the best. At least you have a great quality of life, and you can check for that birth certificate when you get there. Yeah. Well, I knew somebody was awake. Signs of mental activity stir briefly there. Here's another reality which is not an illusion. This is the prevalence data, and you can see the tumors, this is hepatobiliary, then esophageal, then pancreatic, then gastric, then NET. You see the prevalence of neuroendocrine tumors is greater than any of the neoplasias of the GI tract, and greater than any two of them put together, except for colorectal. So the reality of this, it's no illusion, is that this is a massive healthcare burden for the institutions, but nobody wants to take that seriously. If you look at that, if you look at the price of progress, here's the US database here for money put into treatment of disease. You see there for breast cancer, you're up into the 500 million range on an annual basis. And if you look at the far right, you see carcinoid at about 600,000, and some of the neuroendocrine tumors in the parathyroid and thyroid getting some money. So the failure to understand the reality of the prevalence of this disease has led the people who allocate resources to put it into an unfair disparity. And this is an important thing that should be pointed out. We have in the US, and I'm glad to hear that this will be discussed in Ottawa soon. Now let me show you a slightly different thing, which is the illusion of diagnosis. There in blue are the different presenting symptoms as you see them, and in the red are the various misdiagnoses which you go under for a long time because people don't know about this, and there's a 5 to 7 year diagnosis delay from this SEER database. And if you look at this, the concept of switching on people's awareness to diagnosis is a complete illusion, because once you have symptoms, for practical purposes, you have metastatic disease. So getting people to be aware of flushing and diarrhea and sweating and borborygmi and asthenia is an illusion in my aspect. If you think about the great steps forward, you didn't wait for somebody to start coughing up blood and lose 40 pounds in weight to diagnose tuberculosis. You got a chest x-ray of a normal 20-year-old guy to make that diagnosis and cure him. So this is barking up the wrong tree, in my opinion. Now, we talked earlier, and there was a wonderful talk early this morning on anatomical imaging, so I won't seek to adumbrate upon that at all, except to say this is a good step forward, but the limitations are inherent in one thing which I want to point out to you. Here you see Röntgen, and the original picture, you saw the picture of the hand earlier this morning. It's his wife. She wanted, for the prenuptial agreement, an x-ray to make sure that the marriage was in place. Come on. And the point is, when you have a picture like this, using conventional imaging, all the isotope things, and you're picking up tumors of the 1 centimeter or less range, a centimeter tumor has about 1 billion cells in it. Now, when you pick up 3 or 4 lesions, or 5 or 6, I don't have to do the math for you. This is too late. This is the anatomical topography of disease. What you want to be is in the position where you're picking up 1,000 cells or 3,000 cells, because one of the reasons is that you can't cure these patients. It's not that we don't have such good drugs. For instance, think about the Titanic. It's not that we don't have good equipment to pull things out of the water. You can't pull something that weighs 100,000 tons out of the water. You can't treat a disease that has 800 billion cells in it. You need a disease with 10,000, 100,000, etc. So I make the point. We need to find a different way of making these diagnoses. So there was much talk about chromogranin. And I commented adversely as to the acronym for it. Everybody who's trained here knows that is an exocytotic granule coming out of the plasma membrane with the clathrin-coated vesicles, right? Right. Let me show you all the different biomarkers that have been looked at. These are them. And it's not even a complete list. CGA just happens to be the one that's lasted longest. Like Queen Victoria, hung around for a long time, right? Didn't do much good, right? Okay. The others have some limited use, but basically CGA stays with us. Let me show you a big flaw. This is how chromogranin works. Just bear with me for a second. This is the chromogranin vesicular transport and synthesis pathway that I'm delineating for you in a cell. And then at the end, it gets secreted by exocytotic processing, and it works as a hormone, a marker, etc., etc. It has nothing whatsoever to do with proliferation. It's a secretory product of the cell. So the attempt to link it to a number of cells that are proliferating, the number of cells that are spreading, or whether the disease is being treated or not, is a very shadowy piece of scientific thinking. Having said that, it's the best we have at the moment. I just want you to be aware that it's very soft in terms of its intellectual rigor. And if you look at the list which I put together here of in what situations can plasma chromogranin be elevated, that's almost everything that goes wrong in the body is listed up there. Okay? So be aware of the fact that CGA has some serious limitations, but in the absence of anything better, this is what we're stuck with at the moment. And then if you plot it out like this, this is the measurement profile of every plasma CGA that's ever been reported in the literature. One person spent his entire summer at my laboratory doing this, and after that he was institutionalized. But what it shows you is it's all over the place. It's what I call a Zeppelin plot, and you know what happened to the Zeppelin, right? So that's where we are with CGA. 5-hydroxyindole acetic acid, I'll make one comment of. It was probably first used in 18th century Amsterdam. Here's one of the great Dutch artists. He's looking in the urine, and they would diagnose people by looking in the urine. 5-HIA is 50 years old. It's incredibly insensitive for most points of view. It can be messed up by many different things. It's changed by everything under the sun, including the sun itself. And for practical purposes, if you had a Ferrari and you wanted to know how the engine was performing, you wouldn't be measuring what's coming out of the exhaust. You'd be measuring closer to the engine itself. So, I'm starting to lose my audience, I feel like. Let me show you the way it should be going, the place it must be going, all right? These are, I'm switching now to molecular medicine. This is transcript analysis from my laboratory. You see in the circle normal enterochromaffin cells. This is where your small bowel neuroendocrine tumor comes from. This is a self-organizing terrain map, and it's a global transcript analysis. And you can see the circle is the transcripts for normal cells, and on the other side are the transcripts for primary neuroendocrine tumors. They're totally different. It's as different to any person in this room looking at another person, right? You can instantly see they're different, okay? Okay? And so this is what we have to pursue, the discrete clustering between these cells. What one has to do is to find the different genes that are produced related to these cells and the way they change, the way they proliferate, the way they migrate, the way they metastasize, and come up with a series of algorithms to figure out which combination of these will predict how a tumor is going to behave. And this is not that difficult to do. It's over the horizon, and therefore people don't want to go there. They rather stay in town. They don't want to go sail the boat like Columbus, okay? What you can show, and this is data we've published, with 14 biologically relevant marker genes, you can measure them in the blood, and you can tell if a patient has a tumor or doesn't have a tumor. You can tell if they have a tumor even when every single imaging test shows negative. And in fact, how good the tests are in Uppsala that was spoken about, that Oberg and Dr. Granberg do, is by then sending these patients with positive blood transcript analysis to Sweden, and there the test will show a positive. So we can see things beyond the horizon at the moment. If you look at it using the question of answering the question, can you predict in plasma whether a patient has the tumor or not? Here you see the tumors. Oh, I'm sorry, there's something. Can you go back for me, please? Oh, I can do it myself. Yeah. What you can see here is out here the tumors which are primary tumors, gastric tumors, and over here normal. So you can separate them in plasma, and by using some very complex mathematical formula, I'll just show you one over here. You can actually deduce by putting them together whether the patient is likely to have a tumor which is metastasizing, not metastasizing, and what the growth rate will be. And this is completely outside of the skill of any physician. This is mathematical understanding of complex molecular events, all right? And that hasn't been brought in to our net world yet and should be. I just show you then that you can identify them by measuring things in plasma. This is particularly important because when the surgeon tells you he's removed every tumor and then takes images and says there's nothing left, we still show that there's positive circulating transcripts in plasma, and these patients should probably therefore be treated. Here's just to give you one example. You see chromogranin. This is a standard chromogranin measured against the PCR products, and you get a completely different picture. So the PCR products in the blood will show you that there's circulating tumor cells or circulating transcripts, and CGA will show you completely different. And here's another patient showing exactly the same disparity. And then I don't want to show cases here, but to then point out when we investigate these patients, we can identify that the transcript analysis is concordant with the actual patient's clinical status as opposed to the use of current markers. Now, let me switch for a second. I've done illusion, I've done net world. Here's delusion. This is misleading somebody. They don't mean to, but they just may mislead you. So let me show you some of this, okay? And the classic example is histopathology. This is a pancreatic tumor, and this is a series of different histopathologies. These are all neuroendocrine tumors. No histopathologist can tell you possibly what's going to happen to this tumor by looking at this. This is pattern recognition analysis, and it's an art which is now about 100 years old, and we're still using it, okay? They're indistinguishable histologically. Then people say, wait, we got Chi-67. Okay, and you heard Chi-67 and Professor Odorizio on sausage slicing the other day. Now, you also heard from Dr. Liu that the best thing in imaging is gallium-68. So look how limited these people are. Chi means Ki means completely incomprehensible. And then they went up, they made a big step forward. They went from 67 to 68. So now we got gallium-68, right? And here you see the sausage slicing concept of Chi-67 and then the creative way of dealing with it. This is not the way to go. For practical purposes, if Chi-67 is present, you're in trouble, right? And to say it's a bigger sausage or a smaller sausage, it depends which side of the sausage you cut, I don't know. I know Tom will disagree with me, but anyhow. Here I show you 4 different Chi-67 patterns, and I diverge to tell you one anecdote. About a year ago, we ran the Summit Conference on Histopathology. And the first time we actually got 40 of the great histopathologists, all of whom were self-acknowledged authorities, in the room, and we also pulled in, this time, 6 or 8 great clinicians. Right? And we flew them in from all over, so there would be no national bias. You know, they didn't all come from Real Madrid or Barcelona, so they were all over. And I got one of the pathology people who'd worked in my laboratory to prepare 40 slides on Chi-67, different ones. And I really mixed it up. I took some of them and I turned them upside down, and some I turned on their side. So some of them were duplicates, right? right? And then we got in the room, everybody in an electronic thing, and they had to vote the Chi-67 count. Firstly, there was almost no concordance, even amongst the famous people who'd been flown in at great cost, non-stop planes, sleepers, suites, etc. Healthy night, no drinking, so they couldn't complain about that. They counted. And then we compared, so there was no concordance with them on Chi-67. Go back one, I'm sorry. No concordance on Chi-67 with them. Could you go back one, please? Okay. Sorry to wake you. And then we took the 10 clinicians. Now, the 10 clinicians had never counted a Chi-67 in their life. They'd never seen a Chi-67. We just said, compare and put your scores down. We put the scores down. Then we looked at the original correct score that had been done by an automated machine at Sloan Kettering, and we compared them. The machine scored 100, of course. The clinicians who'd never scored Chi-67 in their life scored 80, and the pathologists were at about 58%. So if you're less resting your future on Chi-67, God help you. The American Journal of Pathology, to their credit, actually published this, so it's fantastic. There's no amount of sort of self-inflicted pain that pathologists want to, Anyhow, so what are we lacking? Here's the problem. We can't, at the operation, we can't see any residual disease afterwards. If you're in the operation, even if you have pathfinders and such like, which are wonderful tools, you can't see anything that's below your macular discriminant index. Right? You can't see it. It has to be picked up at a molecular level using fluorophores or Raman spectroscopy or something like that. Nobody uses intraoperative confocal microscopy. Nobody in surgery uses Raman spectroscopy. And we don't use any of the intraoperative fluorophores which could illuminate these tumors. We just operate, right? We're so obsessed with taking it out, we don't pay any attention to what happens when you leave it behind. Now, let me finish with my denouement of this delusion thing, which is therapy, which is nothing more, in my opinion, than a Mad Hatter's party, right? Okay? Moment of silence. Now, you all know the Mad Hatter was poisoned with mercury because he worked in a felting factory. And so it's actually true, the Mad Hatter was completely crazy. And I think if you work with cytotoxic drugs after a while, this is what may happen to you as well. So look at it. This is what we offer people. Biotherapy, chemotherapy, peptide radiotherapy, angiogenesis inhibitors, growth factor inhibitors. It's the roulette strategy, depending where you come, how you feel. There's somebody throw a dice and stick you on a trial. This is terrific, okay? It's the Rat Pack consensus we're looking at here. And depending on which meeting you go to and who's supporting that meeting, you have a sway of the audience to one side or the other as to which it goes. And then I don't know if Aaron Vinnick is in the audience today, but then Aaron, of course, doesn't want to show his data because he says the New England Journal of Medicine are being paid to show it. So that's so we don't even know what the real information is sometimes. And then we come up with these wonderful flow charts and algorithms for how we're going to treat people. Well, this is like trying to find your way through the New York subway system. You've got a 50-50 chance of getting to the other end. Right? And the question of whether you'd get there safely is another thing completely. So I can't say to you that this is anything more than this is the best we got, but you should take it with a serious grain of salt. For the very most part, most people's therapeutic strategies is based on the Frank Sinatra intellectual process, which is, I did it my way. Okay. Not finished, don't panic. So if you look at new therapeutic targets, they're all out there. And we heard a lot of talk about them today, and they're quite wonderful, and they should be explored. Problem is, if you look at the National Academy of Science report from earlier this year, 40% of NIH clinical trials are never completed. So, I mean, what kind of database do you have if only 40% of the trials, 60% of the trials get done? And then the last thing is the NET multidisciplinary team, which gets trotted out over and over again. You line up all the people together, you put the patient in the middle, and you have a very important support group. This is very, very important. I totally endorse and support this. Problem is, multidisciplinary is dependent on the application of the process, and it can be an illusion or delusion in its own right. The fact that you've got 10 people in the room doesn't guarantee an appropriate output from that room. And the reason is because in many cases, What you're looking at is a series of random discussions about a series of different events, all of which then get piggled together as if it's a jigsaw puzzle, and somebody comes out of the other side and says, this is what we're going to do. And usually that's based on the chairman's strategy. There's one person in that group who carries the day. He's gray-haired, he's senior, he's got a powerful personality, he's seen a lot of patients, and he says, this is what we're going to do. Thank you for your input, and we find a way to get this all together, right? And what's lacking is a process, and this is the basis of what a process should be. It doesn't take place in any multidisciplinary board I know. It's based on Robert's Rules of Order, how you walk through coming out of a series of different facts to a point that allows for an inclusive quotient, right? And nobody uses the best one that exists today, which is the DELPHIC consensus of how information that has very many different kinds of viewpoints gets put together to draw out an acceptable conclusion for all participants in the multidisciplinary meeting. So I think excellent to have a multidisciplinary group, must be, but the multidisciplinary group has to be trained to work as a consensus group, not just be all in the same room together listening to each other, okay? So let me finish by the future. This is my thoughts for solving the whole process. Healthcare reform is on the door. We're right here. I see it as net reform. I see a stakeholder table which requires a lot of different people to start putting their pictures into the place of this. And of course, the most important part of this is it has to be relevant for the patients. And this is what I've said I believe should be the mantra for net reform. The patient has to come out understanding the disease, the options, know that their physician is an expert, know all the options available to them, know that novel advances are present, participate in their decision-making process. There isn't one person in this room, I wager, who doesn't know more about neuroendocrine tumor disease than the average doc in a hospital in North America, right? You're all self-educated and highly focused. So the concept that somebody, because they got an MD degree somewhere and knows more about this than you, is not real at all, okay? Except for some of the experts who run these groups, right? And at the end of the day, the life quality has to be maximized, and life quality has a whole series of components to it which have to be very seriously addressed. And this is an important issue that hasn't been focused upon enough in an organized fashion. We talk about it, we haven't organized ourselves around. I propose the solution is going to be education, but I have a different educational solution, and I show it to you here. Here are the number of medical school students and curriculum duration in a number of different countries. If you look at it, you see that there are about 41,000 students coming out a year. So if you were to have one module in each year just on neuroendocrine tumor disease, it wouldn't take more than a week. Remember, it's only a 119-page guideline, right? 1 week to teach these people, and this was every year repeated once. At the end of a 4 or 5 year period, there'd be 250,000 doctors each time who are educated on neuroendocrine tumor disease. Much more effective than these groups of 100 people, 300 people, 500 people, randomly you're coming. And remember, these are the people who are already interested. I'm preaching to the converted, right? What we've got to get to is the 250,000 doctors we turn out every 5 years who know absolutely minimal about the neuroendocrine tumor disease. Then you have a different ball game on. So you need to stake 3 or 4 years of investment, and you'll entirely change the face of neuroendocrine tumor disease. If you look at management stratification, these are all the things that we put in. It's completely arbitrary. People say this is more strong than that, this is what's going to happen, this is what I think based on my experience. There has to be a serious thought to a matrix normogram to define management and prognosis stratification. So I'm closing now. Remember I said illusion, delusion, and reality. If you looked at Vancouver in 1810, this picture was taken on May the 15th of 1810. You believe that? You will see that's where we were. In 1910, people said, well, it's still a delusion, 100 years later, that this is going to be where we are in Vancouver. And if you look at Vancouver now, in 2010, it's a reality. So it took 200 years to get to this point. I show you, this is the acquisition of expertise slide in neuroendocrine tumors. It's only 30 years. We've only been going 30 years. So if it took 200 years to make a city like that, I would say that we're well on the learning curve and that the reality for handling neuroendocrine tumors is very close. I would say within the next decade or two, we'll be on top of this. The progress made is extraordinary. If you think of lung cancer, ovarian cancer, breast cancer, people have been looking at it for 100 years. So I think the distant reality is there. So I've wandered around a little bit in terms of showing you where we've come and where we're going and what's good. And what I try to give you is the application of scientific rigor to disease management, the so-called Foucault-Modlin concept. And if you remember, this is the Foucault equation. I showed you the mathematical equations to take gene transcript analysis and put it into clinical practice. They're not that much different. So, you know, I can't do this on my own. This is the Yale Imbibimetry and Exocytotic group, and I take pleasure in presenting this work on their behalf. Thank you very much for the opportunity and the privilege.